Okay, we'll get started. So I wanted to, for this lecture and this review, we're doing case studies. There's no Kahoot for this one. I'll tell you why. I know you're disappointed. The reason is now is when the questions are going to start changing up a little bit on your exams. You're going to get a lot more vignette questions, how to read a bunch of case studies and analyze it to get to the answer that you need to get to. So there's 10 case studies that we're going to go through. Please be quiet in between. I'll give you guys a few seconds to kind of think on your own, to come up with your own answer before everyone starts shouting out the answers. But we'll go through the question, figure out what's going on, why is this piece of information important, why is it not, as we go through this. So it's just kind of just relax, pay attention for this topic. So let me, okay. So case number one, we have a 31-year-old male. They're always going to have the age on every vignette. Why is the age important? There's a lot of different things that are going to be affected and your differentials based off of the age of the patient. So always know what the age of the patient is. And they're always going to say they have a history of IV drug use and comes to the ED with a complaint of shortness of breath. So already we know the patient's an IV drug user. He's short of breath. So we start talking to the patient. We get some more information. He's got a 1-month history of intermittent fevers, night sweats, with a non-productive cough. Okay, so if he's an IV drug user and he's said, yes, I am an IV drug user, you already know risky behavior profile is associated with that patient as well. So you obviously, when we get to the other conditions, you'll see what's going on. Initially, the shortness of breath was only with exertion. So whenever we was going to do activity, the shortness of breath got worse. But now he feels dyspneic at rest. So what does that mean? What's going on with the course of his disease? It's getting worse. It's progressing. At first, he could still be okay at rest, but now he's getting short of breath at rest. So the disease is getting worse. And when you do your inspection, moderate respiratory distress. So there's a lot of things this could be. A lot of things you'll be learning when you get to like Palm and cardio and the CMS courses. But obviously we are in cardiac, so we know it's a cardiac issue, but it also could be inflammatory infectious, because we did that in the very, very beginning too. Okay, so let's look at the vital signs. Temp is 39 degrees Celsius. Is that high or low? High. Heart rate? High. Respirations? High. O2 sat? Low. So we know he's fever. We know that he's got signs of sepsis, right? Remember this? What are the, or not sepsis, but the systemic inflammatory response syndrome. What are a couple of those parameters that you have to have? High heart rates. What else? Fever, respiration rates, white blood cell count, which we don't know yet, but we're getting there. But we've already have 3 of them, so we know he's got SIRS. Physical exams, lungs, clear to auscultation bilaterally. That's what CTA means. If you're my advisee for your note, you can just write that for this semester. It's fine. That's all you need. You don't need to write novels. Just CTA bilaterally. That means to me that you listen to the lungs. There's no, you can also put no NABS, no adventitious breath sounds. That means you listen to the lungs, you didn't hear anything abnormal. There's nothing more to write. No wheezes, rails, or rhonchi, which are the no adventitious breath sounds. Those are the abnormal breath sounds that you would normally hear on a physical exam, or shouldn't hear. Otherwise, unremarkable. Chest x-ray, diffuse interstitial infiltrates, characteristic of pneumocystis pneumonia. Okay, is that a normal type of pneumonia? No, it is not. Okay. Okay, so what is the underlying disease most likely, this is where I'll give you guys a few seconds, responsible for this man's susceptibility to this type of pneumonia. Okay. What is it? HIV/AIDS, remember? They have these weird opportunistic infections, types of things they get. Those aren't normal. HIV/AIDS. And then what's the pathogenesis caused by this underlying disease? So basically, how does HIV work? Simplified it really simply, and you're going to have all the, when I give you the presentation, you'll have it all. But it'll all be there. Yes?
Is it possible for us to get access to this with PowerPoint now? That way we can...
Yeah, I guess I can give it to you guys now. Hang on a second. Let me just upload it real fast. Okay, it should be up. So make sure it's the right one. It should come up in a second. Okay, is it there now?
Yes.
Okay. Okay, that's the right one. Okay. Okay, so remember, with HIV, the virus attaches itself to the wall of the CD4 receptors, injects its DNA, replicates inside that host cell, and then when it's killed that cell enough, cell bursts open, all those new HIV viruses then float around to infect the next set of CD4 receptor cells. And that's what happens with HIV. Okay, so remember with natural history of this disease, there's a long latent stage. They can live with it for 10 years. And then when the host immune system starts to decline to a level where these opportunistic infections can now start taking hold, CD4 counts drop to a certain level, then you become full-blown AIDS, acquired immunodeficiency syndrome, and then those other infections, cryptococcal meningitis, toxoplasmosis, CMV, so on and so forth, they start popping up because a normal immune system can handle those things easily. With their weakened immune system, they can't. Okay, case number 2, 45-year-old male presents with a history of shortness of breath, irregular heartbeat, and hemoptysis. Okay, what's the irregular heartbeat most likely going to be referring to? Atrial fibrillation. So whenever you see irregular heartbeat, just think at first atrial fibrillation. You'll get more information as you start looking at EKGs, but for now, just assume irregular heartbeat, atrial fibrillation. And what's hemoptysis again? Coughing up blood. Okay. Over the past 2 weeks, he's become easily winded with minor activities. So is the disease getting worse or better? Worse. So we know we're deteriorating, we're progressing in the disease. Coughing up some flecks of blood on occasion, that's the hemoptysis, and fast heartbeat and occasional pounding in the chest. And no fart. So yeah, put fast heartbeat together, you get that. Okay. Past medical history includes being ill for several weeks after a sore throat in childhood. What do you think that is referring to most likely? Rheumatic fever. What valve does rheumatic fever mainly affect? Mitral valve. Okay, so start keeping that in mind as you're reading these questions. Start thinking of the words as they pop up. One of the great things you guys can do, like at the end of the semesters, to see how much knowledge you have, listen to drug commercials. And when they read off the side effects, when they go really fast, you'll be able to keep up with those words because you'll know what they mean now. So as you're going to want to see how much knowledge you have, watch a drug commercial to see what the side effects are and see if you know what they mean. Vital signs, heart rate 120 to 130, irregularly irregular. There should be BM in there. Okay, is that fast? Yes, that's tachy. Irregular, that's always referring to atrial fibrillation. Physical exam, JVD is noted. What does that mean if JVD is noted? We have congestion. What side of the heart? Right side of the heart, right? That's the only way you can get JVD. Left-sided heart failure by itself at first will not cause that. Over a long period of time, it can. Why will left-sided heart failure eventually cause JVD? Because left-sided heart failure is the cause for right-sided heart failure. And that's why that would be linked up. However, in this situation, we're just talking about JVD. What are some reasons for JVD to be elevated? One of them is heart failure. What's the other one, which we learned about? We'll get to it later on in one of the case studies. Pericarditis, pericardial effusion, those type of things. The heart can't relax, so it can't fill. You get congestion, and it works when we're back up to the JVD. Lungs, rails at bilateral bases. When you see rails at the bases, what does that mean? There's fluid there. Why at the bases? Gravity. We're sitting up straight. So you have more of that fluid, gravity going to fill the base. So we know they're in pulmonary edema. They have some sort of congestion in the lungs going on. Cardio, irregular heartbeat, soft, diastolic, decrescendo murmur, loudest at the apex. What valvular area are we referring to? Mitral valve. See how the pieces are starting to come together as far as your diagnosis are concerned. Okay, EKG does show atrial fibrillation with left atrial enlargement. Okay, so as you think you have a diagnosis in your head, whatever diagnosis that you think you're landing on, does it have a reason to cause left atrial enlargement? Does it have a reason to cause that type of diastolic decrescendo murmur? We're talking about a diastolic murmur. There's only 2 valvular abnormalities that are going to have a diastolic murmur. What are they? Aortic regurg and mitral stenosis. Those are it. So already in a multiple choice question of 4 answers, the minute I tell you it's a diastolic murmur, 2 of your murmurs should be gone already. And what are the other 2 that are systolic murmurs? Aortic stenosis and mitral regurg. Those are your systolic murmurs. Those are the only 2 it could be for a systolic murmur. Okay, now some of the questions you're going to be getting mainly in the CMS classes, not so much in mine. You'll have some of them. Where I'm going to give you the scenario, and I'm not going to tell you what the diagnosis is. I'm going to tell you what's the next best step in treatment for that, where you have to make sure you have the right diagnosis or you're going to get the wrong treatment for that question. Does that make sense? Or we'll give you everything. We'll say, what's the most appropriate diagnostic test for this patient? But I don't tell you what the diagnosis is. You got to figure that diagnosis out from the vignette, and then you can go from there. Okay? So, what's your most likely diagnosis? What's the cause of this patient's problem? Mitral stenosis. Did everyone get mitral stenosis? Okay. What elements in the history, physical exam, and EKG are also going to support that? And I'll just, obviously you have the stuff. So, shortness of breath, hemoptysis. We get backup of fluid in the lungs. It increases pulmonary capillary pressure. They don't like high pressures and they burst. And that's why you get blood in the lungs and you cough it up. AFib. Okay. The left atrium gets enlarged. Enlarged chambers don't react well. They don't like it. And the left atrium, that's where a lot of the atrial fibrillation foci come from, in that left atrium. That's why they have atrial fibrillation. Left atrial enlargement, because the valve doesn't open up all the way. So what happens to the volume of blood in the left atrium? It increases. Also, we're having a squeeze through a very tight stenotic valve, right? That requires higher amounts of pressure to get through a tighter valve area. The left atrium has to work harder. It's going to squeeze harder. That muscle is going to hypertrophy, and that chamber size is going to get bigger. Okay. Rales, again, backup of fluid in the lungs, causing the rales to happen. The diastolic murmur is due to that stenotic valve, and then obviously murmur is always turbulent flow across that valve. Now, I may say, I give you all that, and maybe I don't give you some physical exam findings, and I say, based off of that, is this going to be a diastolic murmur or a systolic murmur based off of clinical scenarios and stuff like that? What neurological complications can this patient develop with mitral stenosis? So we'll talk about neuro stuff now. What happens to that blood as it sits in that left atrium? It clots. And if you have a clot and it breaks free, that clot that's in the left atrium is called the thrombus because it's fixed, it's attached to the wall. That is the thrombus. If a piece of that breaks off or the whole thing breaks off, now it's called an emboli because it's traveling. When it leaves the left atrium, left ventricle, aorta, carotids, brain, stroke. That is the major neurological complication with mitral stenosis is cerebral vascular accident, CVA. So when you're seeing patients with mitral stenosis, atrial fibrillation, we know those patients are higher risk for strokes. We want to prevent the stroke. So a lot of the treatments that you do are there to prevent that stroke from occurring. Any questions about case 2 with mitral stenosis? Getting an idea of how to read through these vignettes, how to pull pieces of information out as you're learning, how that makes sense. Okay, next patient, 55-year-old male, presents to the clinic with chest pain. Okay, reports intermittent substernal chest pain or pressure, radiates to his left arm for 5 months. So it's been going on for a while. Okay, what's the first question you need to ask these patients when they come to see you? Why are you coming today? You've been having this for 6 months. Why today of all days do you decide to come in? Now, I'm not trying to make fun of you for why you're coming in, but like what changed in your clinical scenario that made you want to seek attention today? What is it? Did something change? Did the chest pain get worse? Did the chest pain get to a different area? Now you're coming to see me? So start thinking of these things as you're studying. Pain occurs primarily when he exercises vigorously and is relieved with rest. Denies any other symptoms associated with it. So chest pain with exertion, right? Everyone understand that? So what kind of angina would that be? Stable. Okay. So past medical history, positive for hypertension, hyperlipidemia. Medications, he's taking a atenolol for blood pressure. Start getting in the habit of, now you guys are starting to write notes, interviewing patients. Whenever they tell you what med they're on, make sure you have a diagnosis for why they're taking that medication. They'll say, as you do like start interviewing patients, you'll say, well, do you have any high blood pressure? No, I don't have high blood pressure. Do you have any high cholesterol? No, I don't have high cholesterol. What med are you taking? Oh, I'm on Lipitor. Why? You see, like patients will forget. They don't understand why. So on your end, just fill in Lipitor for high cholesterol, atenolol for hypertension. This way you're tracking their meds. You know they're not on any meds for no reason. It's just a way to make sure that, and also you're checking your patient to make sure you're hitting all their diagnoses. Family history, father died of MI at 56. Is that significant? Yes. Social history, 50-pack year smoking history. Okay, he's trying to quit, eats a low cholesterol diet. Blood pressure, a little bit elevated. How's the pulse? That's fine, pulse is okay. Just a little slight high blood pressure. Physical exam, the rest of it's within normal limits, it's okay. Nothing else significant to add. Yes? You have a question? Okay. Yeah.
On the other side, what does N and V stand for?
Oh, this? Nausea or vomiting. Shortness of breath, nausea or vomiting, or their diaphoresis. Because remember, when they come in with acute chest pain, they may have nausea, they may have diaphoresis, some sweating, and so you want to ask those questions, and obviously shortness of breath as well. Okay, so this is, okay, we talked about that already. It's stable angina. Okay, it only occurs with exertion. What are some causes of this disease? What are some contributing factors in this patient? Obviously, it's smoking and the hyperlipidemia. I think that's it. Yeah. Okay. It all got messed up. Atherosclerosis. He's got smoking, hypertension, and hyperlipidemia. Those are all risk factors for atherosclerosis. That's what's causing the lumen to decrease in its size. And then obviously he has risk factor for coronary disease, just the smoking, hypertension, hyperlipidemia. You can also include family history as well, because the father had it at 56. Okay, I don't know this. Anyway, how do atherosclerotic plaques form? Remember those shear forces. So a lot of this stuff is just review as well. Vessel wall has those injuries. When you have these injuries, we have to repair them. The problem is LDL gets sucked in there by the macrophages, causing foam cells. All those oxidized LDLs causing all those issues. And then obviously, when plaque formation causes angina, that decreased lumen size doesn't provide very much supply anymore. So when the demand for oxygen goes up, the demand can't meet it because you have coronary artery disease, and therefore you get chest pain because of the mismatch. Okay, case 4. 35-year-old woman presents to the ED complaining of chest pain. Is it normal to have a 35-year-old female come into the emergency room with chest pain? No. Is the likelihood of that being cardiac? Not very high, not, as far as not being a heart attack. No, she's 35, she's young, she's a female, and what's cardioprotective for females? Estrogen. So I'm assuming at 35 she's not menopausal, she's still fine. But anyway, again, start thinking, hey, this age with this complaint, does that make sense? So when we get through this question, you'll see what's going to happen. So the pain is described as 8 out of 10, retrosternal in location, sharp in nature, like someone stabbing you. Does chest pain present with knife-like stabbing pain? It's pressure pain, over an area. I can't point to an area of my chest where it hurts. It's kind of a broad Non-localized is where cardiac, true heart attack pain is going to be. Radiates to the back and worsens with deep inspiration. Does cardiac pain, true chest pain, have any change in intensity with breathing? Nope. Okay? And pain improves when she leans forward. Do you see how your OPPQRST questions come into play when you're doing these little vignettes? Okay, all those questions that you ask, they're all going to be here, and that's why they're important to ask these questions. What makes the pain better? What makes the pain worse? How long has it been going on? Where is it located? Can you describe the pain? How does it feel? These are all questions you have to ask during those histories. In your review of systems, okay, your general, have you been sick recently? Yeah, I had a flu-like illness over the past several days, fever, rhinorrhea, and cough. What disease did we learn about that's an inflammatory process that causes chest pain and usually happens after a recent illness? They're better with leaning forward, pain is relieved, pericarditis. Very good. Past medical history, negative, no medication, social history is all normal. Vital signs, how's her blood pressure? It's good. Beat, pulse, a little bit high. Obviously, she's in some distress. She's got chest pain. I'm sure everyone who had an episode of chest pain, your heart rate will be higher too because of anxiety, just worried about it. Respirations, normal, it's okay. Temperature is okay. O2 sat is okay. Physical exam, moderate distress from pain. HENT, because she complained of illness in the weeks preceding this, so it goes under the history of present illness. That's why you want to check it, because it's close enough to why they're here today. Also, in your differential list, if you're thinking pericarditis, one of the clues of pericarditis is a recent illness. So it all relates to why they're here. So HENT is okay. Mild erythema to the pharynx and the throat. Neck is supple. Shoddy anterior cervical lymphadenopathy. So she's got some lymph nodes that have popped, which means what? If lymph nodes are enlarged, you're fighting off an infection. You need more troops. You got to grow more white blood cells. Those glands get bigger. No JVD noted. Why is that very important in this case? Yes?
What is shoddy?
Shoddy seems like very hard to feel, but you can feel them. They're not like popping out, but you can feel that they're like larger than normal. No JVD noted. Why is that important in this case? What can pericarditis lead into? Pericardial effusions and pericardial tamponades, which are any cause of pericarditis can lead to the more severe forms, pericardial effusion and tamponade. When you have those things, what are the three? It's Beck's triad. You got to know this one. So when you're studying, make sure you know that one. Muffled heart sounds because they have fluid over the whole heart. They have JVD and hypotension. So you'll learn that eventually. Again, remember guys, you're going to get this information again with Dr. Ovalle when it comes to cardio. So you're going to get it repeated again. Heart, tachycardia, which are vital signs, showed a heart rate of 102, 105. Yes, they're going to be tachy on physical exam as well. With a high-pitched squeaking to and fro murmur. So this murmur will be heard in systole and diastole. It goes across. Only one that really does that is the murmur with pericarditis. Lungs are normal, abdominal is normal, extremities are all normal.
Question.
Yeah,
Oh.
yeah, a question?
I thought pericarditis did have G.
If it progresses to pericardial effusion, not all the time.
In my notes it said there's like a small sign.
That's increased right atrial pressure with inspiration, not the JVD. I mean, it can translate up in the more severe cases, but normally with simple pericarditis, they won't have JVD. it can progress to it. So the point of that one was that any cause of pericarditis can lead to pericardial effusion and tamponade, which will give you JVD and muffled heart sounds. So diagnosis of pericarditis. Now, let's say I gave you that scenario and I said, which of the following scenarios would be the cause of this patient's pain? Answer number 1, blocked vessel. Number 2, let's say they got trauma to the chest. Number 3, pericarditis. Or, I'm sorry, Coxsackie virus. Number 4, I'll say, I don't know, it doesn't matter. But you understand how I said the patient comes in presenting with these type of things. I don't give you the diagnosis, but I say which one is the most likely underlying cause. And the most likely underlying cause of pericarditis, Coxsackie virus. She was sick recently. So I'll give you an example as I did before. I'll give you all this information. I will not give you the diagnosis, and I'll say, what's the most likely cause? Yes?
Is that how this test is going to be laid out for you, or is that how future tests?
This one and future tests. I mean, you can get them both ways. Because my class only ends at diagnosis, signs and symptoms, I don't ask any questions about treatment diagnosis. I kind of say, why are they presenting with this? Why are they having this complaint? In your other classes, they will go and say, what's the most likely treatment? What's the most likely diagnosis? Patient education, things, stuff like that. Okay, pathophysiological mechanism for her chest pain, inflammation of the pericardial sac, and that causes the chest pain. So the sound heard on cardiac exam, that pericardial friction rub. The 2 layers of the pericardial sac get inflamed and irritated, and they rub back and forth. The 2 possible complications from this disease, and this goes into the whole pericardial effusion and tamponade, and then obviously the effects of JVD when that happens. Okay, case number 5, 56-year-old male. Okay, routine physical exam, not seen anyone for 10 years, and BP is 160/90. And I don't know why the thing didn't work, but does this man have hypertension? Yes, because he's greater than 140/90. What physical findings might be present if he's had long-term untreated hypertension, hypertensive retinopathy, that is the eye changes that go with long-standing hypertension. You might get bruise as well from all those shear forces causing plaque formation to occur. And what are some important complications of hypertension? Remember, we went through all of these things, explained why. There's that big chart that had all the different algorithms that have the, starting with hypertension. It causes, obviously, cardiac issues, and it causes vascular issues. And they both combined together downstream will cause all those things to happen. And some other causes of hypertension. Remember, primary hypertension is unknown, idiopathic hypertension. There really is no main cause for it, but secondary hypertension has a root cause. There's an underlying condition that's causing it. Pheochromocytoma, that is the tumor of the adrenomedulla that when compressed squirts out all your catecholamines, your blood pressure spikes, giving you high blood pressure. Cushing's is high cortisol, brings your blood pressure up. Renal hypertension, that is the renal artery stenosis. Remember, you are tricking the kidney into thinking it's getting less blood. Therefore, it thinks that one kidney thinks you're having hypotension. It needs to push out renin to get that cascade going. But that's going to raise your blood pressure artificially, but you don't need it. And the last one is estrogen. Remember, this is that pill hypertension, okay? On birth control or hormone replacement therapy with too much estrogen causes a rise in cortisol, which will cause your blood pressure to go up. And that's where this whole estrogen comes in with blood pressure. Everyone good so far? Making sense as you go through these questions, putting things together? As you start learning, you're going to fill in a lot more information. And your differential lists are going to start getting longer and longer and longer because you're going to learn more medicine. So later on, at the end of the next year, I'm going to say, what causes a headache? And we're going to fill this entire board with diagnoses that can cause a headache. And you'll see as we go through our history, the physical exam, we're going to start checking things off. Crossing off diagnoses that don't fit the description of their presentation. They're all presenting in a certain way, and your job is to figure it out. Okay, next case, a young woman brought to the ED after a severe motor vehicle accident. She's unconscious. BP is 64/40. Heart rate is 150. She is intubated and being hand ventilated. No evidence of any head trauma. Pupils are 2 millimeters and reactive, and she withdraws to pain. What this is telling you is that her neurological system is still intact. So she's just going through something else, which we'll talk about in a second. Cardiac, no murmurs, gallops, or rubs. Lungs, cleared auscultation bilaterally. Abdomen is tense with decreased bowel sounds. I'll explain more about that in a second. It's just part of the scenario. It doesn't really matter. Extremities, pale, cool, and clammy. Pulses are very thready. That means is you can feel the pulse, but there's no impulse behind it. Why is there no bounding impulse behind the pulses that you're feeling? What's going on with this patient? Hypovolemic shock, right? Look at her blood pressure. 64/40. There's no pressure in this system. Heart rate is high. Why is the heart rate so high? We're trying to compensate for that low stroke volume, low blood volume. So again, to maintain cardiac output, heart rate has to increase now to compensate. So the heart rate goes crazy, but it's not pumping anything. So when you feel that pulse, it's not going to be a nice bounding pulse. It's going to feel weaker because there's less blood to cause a movement of the vessel. Again, pale, cool, clammy skin. All forms of shock have that except for one. Which one does not present as cool, pale, and clammy? This is your distributive shock. Distributive shock, they're going to be warm. Blood is going to go to those areas and you're going to feel warmth. Vasodilation with distributive shock. Yes?
So the mentioning of the fact that she's still responding to stimuli, that's why you want to be distributive, as well as the fact
Correct.
that she's still
Okay. Despite aggressive blood and fluid resuscitation, the patient eventually does pass away, unfortunately. So let's talk about shocks. There are 4 major types of shock. Hypovolemic, which is what she had. She was in a car accident. The reason why she had a tense abdomen, again, your question won't be as complicated as this, but the tense abdomen, she had internal bleeding. She probably had like a splenic rupture, a lot of intra-abdominal bleeding. That's why her abdomen wall was very tense, because of all the fluid being built up from all the blood. So that's the hypovolemic. Obstructive shock. What are some examples of obstructive shock? These are things that are obstructing the flow of blood. Pulmonary embolus will cause an obstructive shock. Anything that's blocking flow of blood will be obstructive. Cardiogenic. Massive pump failure. You had a massive heart attack. That pump is not working anymore. There is no movement of blood. Immediate pump failure, immediate shock. This is cardiogenic because the pump is just out, not working. Distributive shock. What are some examples of this? Anaphylactic shock. Okay, reactions when they get anaphylactic, they get very sweaty and warm. That distributive, why are they getting so warm and vasodilated in a distributive shock? What I mentioned, what's the major cause for a distributive shock? Anaphylaxis. What type of hypersensitivity reaction is anaphylaxis? Type 1. Type 1 is the A. which is what type of reaction? Allergic. If you have an allergic reaction, what chemical is being released en masse? Histamine. What does histamine also cause? Vasodilation. And that's why distributive shock has warm skin, that vasodilation from all that histamine that's being dumped into the body from that hypersensitivity reaction. Okay. Cool, pale extremities. Again, inadequate volume to fill. We shunt blood away from the extremities to the core. No blood in the extremities. They get cool because no blood's there. And as far as what forms of hypovolemic shock, remember there are different causes. If I have open wound to the air, the environment, then obviously you're losing blood that way. Motor vehicle accidents, those crush injuries, the spleen can rupture. It's got a lot of blood supply through the spleen, internal bleeding, and so forth. Okay, that one makes sense. Okay. Case number 7, Mr. John Smith is a 55-year-old male, comes to the ED complaining of increasing fatigue, shortness of breath, swelling in his ankles and legs. So he's filling up with fluid, he's having problems breathing, his activity levels are diminished, he's getting very fatigued very easily. Has a history of hypertension, but has not been taking his medications regularly. So basically, untreated hypertension. If they say they're not sure they're taking it, or they take it here and there, just assume they don't take it. Okay, medication compliance is one of the biggest things you're going to have to deal with in medicine. I'll tell you one of the problems with high blood pressure. You don't feel high blood pressure. You don't feel any different if it's a little bit high, a little bit low until it gets in the extremes. Really high blood pressure, you'll get a little bit of headaches. Low blood pressure, you'll pass out. When I tell a patient, hey, your blood pressure is 150, 160, we need to get that under control, here, take this pill every day, they're not going to feel any different every day. So they don't realize they have to take it. If you're sick and I have to give you antibiotics, you're going to feel better in 2 or 3 days because the antibiotics are working. So you're more likely to take the antibiotics and finish them because you feel different when you take them. You don't feel different with blood pressure medications unless you're in those extremes. That's why people forget to take it. Same thing with like cholesterol. There's no changes to your body if you're taking cholesterol medications. You're not going to feel any different. And that's why they forget those meds. Also admits to a 20-year history of heavy alcohol consumption, but he claims to be reducing that over the past few years. But again, long-term alcohol consumption. And he's got swelling in his ankles, shortness of breath. What are you thinking of right now? He's got heart failure, but he also got an alcoholism. So as you start thinking about what other cardiomyopathies are having problems with alcohol. So look at his vital signs. BP. Is that high, low? Good? That's high. Heart rate, respirations, high. So we obviously know he's in some sort of distress. He's anxious and uncomfortable. Physical exam findings, bilateral pitting edema. If I said unilateral pitting edema, what are you thinking of? Clots, deep vein thrombosis. Remember, heart failure will present bilateral swelling. Bibasilar crackles on auscultation. Okay, fluid in the lungs. Heart sounds are distant. Heart sounds are distant. Why? Because you're trying to listen to the heart through fluid in the lungs. So it's going to sound like it's further away because you're having to listen through fluids. S3 gallop is present, and jugular venous pressure is elevated at 10 centimeters of water. Don't worry about that number, just know JVD is up. So we've got backflow in the jugulars. Blood counts, CBC, normal. So if a CBC is normal, what does that tell you? No infections. He's not anemic. Anemia can cause chest pain as well. Okay, so that tells you right there, he's no infection and he's not anemic. Platelet counts are good, so there's no risk of any issue with platelets and bleeding. BMP is normal. What does that tell you? If the BMP is normal, electrolytes are okay. We know his potassium levels are good. What else is in the BMP we're going to look at? Sugar levels. Okay, sugars are controlled. They're okay. What else is in the BMP? Renal function. Remember, they're coming in with volume overload. They're swelling in the ankles. They have JVD. That means there's too much volume in the system. There's two ways to get overload fluid volume. Heart's not pumping, or the kidneys aren't filtering out fluid. You want to figure out when they come into the hospital, is this due to the heart or is this due to the kidneys? If the BMP comes back normal, kidney function is normal, it's got to be heart. You see why these labs are important? Have a reason for doing these labs. Why am I doing this lab? What's it going to tell me? BNP. What is BNP? It's a hormone coming out when the ventricles get stretched due to volume overload. It's too much volume. The heart essentially is like a balloon. The more volume you put in it, the bigger it's going to stretch. And it's elevated. And that confirms that we are in fluid overload. You can have an elevated BNP with chronic kidney disease and being fluid overloaded from that. It's just a marker of volume status. It doesn't know the reason for that volume overload. It just knows that we have too much volume in the system. Our ventricles are getting stretched. Is the heart not pumping? Are we not producing any urine to get rid of that excess fluid? Chest x-ray, cardiomegaly. What's cardiomegaly? Heart's gotten bigger now. Not a normal size heart, it's gotten bigger. When you guys start medical imaging next week with Professor Perez, you'll go through x-rays. You're gonna learn how to read chest x-rays, extremity x-rays, echoes, all that stuff, fun stuff. And you'll start using the anatomy table again too, because that has slices for CT, MRI, CAT scan, x-rays, all that's in there. Pulmonary congestion. Why are they gonna have pulmonary congestion? Blood's backing up from the heart. It's getting congested in the pulmonary vasculature, and you will be able to see that on x-rays. When you get to that class next week, you'll start seeing them more. Echocardiogram. This is the echo, not the EKG. This is the ultrasound of the heart, looking at the size, the volume that's moving in and out of the heart. This is showing you that we have left ventricular dilation and an ejection fraction of 20%. Is that low, normal, or high? Low. What's normal EF? 55 to 65%. So we are very, very low. So we have a very big heart. It's dilated. Our ejection fraction is very low. He's got a history of alcohol abuse. He's coming in with signs of heart failure. Starting to put all the pieces together makes sense as far as why it's this diagnosis of what it is. So, diagnosis, dilated cardiomyopathy. Did everyone come to that answer or understand now why it's a dilated cardiomyopathy? Okay, and how does it relate to his presentation? Heart chambers enlarged, the walls got thin. Those contractile properties don't line up. What are the risk factors for developing dilated cardiomyopathy? Again, we already talked about it. ETOH is toxic to the muscle. And again, chronic high blood pressure leads to filling problems and so on and so forth. Everyone good? Okay. And why or how does the elevated BNP level in Mr. Smith's blood reflect his cardiac status? The higher that number, the more volume overloaded they are. Essentially what it comes down to. Okay. Case number 8. Sarah is a 10-year-old girl brought to the ED by her parents. Known history of a severe peanut allergy and mild allergic reactions like itching and hives after accidental, yes?
I'm sorry, quick question
Yeah.
on the last one. Where does the estradiol come from in dilated cardiomyopathy?
It's the blood hitting the wall of the ventricle of a stiff ventricle.
Okay.
So if this is your ventricle, the blood hits it, it's going to make a sound. That's what S3 is. S4 is that atrial kick, trying to get that last little squirt of blood in, makes an S4 sound. Okay. And there's different ways to remember that. The S3 is Kentucky. Kentucky, the E part of Kentucky, the syllable, is the S3. The S4 is Tennessee, Tennessee, because the 10 is the S4, the knee is the S1, and the C is the S2. Tennessee, Tennessee is S3, S1, S2, or 4, 1, 2. Kentucky, Kentucky is S3. So easy to remember those two. Yes?
For the dilated cardiomyopathy, is that something that's caused by like congestive heart failure?
No, his problem was the alcohol. The 20 years of alcoholism caused the dilated cardiomyopathy, which then led to the progression of his symptoms to be in heart failure. So in his case, it was the alcohol that started the whole thing.
Okay.
Okay. Any other questions? Okay. So we have a young girl, accidental exposure to peanuts. Okay. And they come in because she had a peanut butter sandwich at school for some reason, and now has sudden and severe symptoms, including facial swelling, difficulty breathing, rapid heart rate, anxiety and restlessness, of course, hoarseness and stridor, and obviously nausea and vomiting. Okay, these are all signs of a reaction. Obviously, we know what's going on in this patient. She's in significant distress. Vital signs, blood pressure is 90/60. Is that high, low? Low. Remember also in kids, we haven't gotten there yet, but in peds, they're going to have a higher blood pressure than normal, and it comes down as you get older. So for them, having 90/60, for you, you might be okay, but for a kid, they're going to, that's very low for a child. Heart rate 140. Again, we are in what type of shock? Shock. Distributive shock. Dumping of histamine. Vasodilation. Warm extremities. Distributive shock. Vasodilation. Not enough pressure, volume in the system to keep the pressure up because of that marked vasodilation. Heart rate to try and compensate for that low stroke volume. Respirations is 30, and O2 sat is 88%. Be very careful for airway protection. Okay. Physical exam, facial swelling, the urticaria, hives all over the body, audible wheezing on auscultation of her chest. And what type of reaction is this? Type 1, IgE mediated, where IgE is always the allergic response one. And that release of histamines causes that edema of the bronchioles, obstructing the airway, vasodilation with distributive shock. Type 1 hypersensitivity reaction. Which one is type 2? Type 2 is C, remember acid. Cytotoxic, which means cells have to touch. Cell to cell. What's the most common one of that one? Transfusion reactions. Cell to cell type reactions. Type 3 is the I. What's the I one? Immune complexes. So you have the antigen antibody complexes, and they get deposited into your tissues. That's very common in what disease that we talked about? Lupus. The fourth hypersensitivity reaction is the D. Which one is that one? Delayed. Happens 24 to 48 hours later. Peanut allergy within minutes. Delayed one, 2 days later. What are some examples of that one? Poison ivy, poison oak, nickel, the TB test on the skin, the TDP, whatever they're called, DDP. I can't remember what it's called. That's not Tdap, that's something else. PPD, that's it. Okay, next case. Mr. David Johnson's a 65-year-old male, comes to the emergency room complaining of fever, lower abdominal pain, dysuria, painful urination, and confusion. Her wife reports she's been feeling unwell the past few days with worsening symptoms. Upon exam, He's acutely ill and confused. Vital signs, obviously he's got a fever. Heart rate, 120. Fast, slow, normal. Fast. Blood pressure, low. Respirations, high. Physical exam reveals lower abdominal tenderness, CVA tenderness on the right. What are you checking for CVA when you pop them on the back of the kidneys, right? See if there's any infection in the kidneys or any issue there. Some suprapubic discomfort. Urine output is diminished and he appears dehydrated. Okay. Diagnostic tests and results. CBC, elevated white count. He's fighting off an infection. Okay? And we're learning to put the pieces together to solve the puzzle. Okay, so he's got an elevated white count. He's fighting off an infection. Urinalysis, presence of pyuria, pus in the urine, bacteriuria, and hematuria. Okay, so obviously there's an infection going on in the bladder. Urine culture, positive for E. coli. Blood culture, also positive for E. coli as well. Okay? So, this guy, is he SIRS, sepsis, or severe sepsis? Okay? Severe sepsis, he's not in septic shock. What's the difference between sepsis and severe sepsis? Confusion, end organ damage, or septic shock is more not responsive to pressors. I'm sorry, but we have a documented infection. We know what's causing it, and he's got some confusion. He's not in shock. BP is relatively okay, but we don't know if they were unresponsive to pressors or not. So in a question on your exam, I won't make it as ambiguous. I will give you a list of the things I would say. So remember, SIRS does not have what? A culture. Sepsis has the culture. Severe sepsis has evidence of organ damage. And then septic shock means you're not responsive to any type of pressors at that point. Okay, so remember those different signs. That's what the purpose of this case study was for. Okay, we'll learn about one, but study the other ones as we go across too. Last case. So the other Mr. Smith from before, this is his brother coming in. Gradual onset, shortness of breath during activities. Occasional episodes of chest discomfort with exertion. Past month, notice dizziness and near syncope when standing up suddenly. Denies any orthopnea, paroxysmal nocturnal dyspnea, or palpitations. No history of any recent upper respiratory infections, fever, or weight loss. So why is this mentioned? Why is that important? Because there's no viral preceding event. Based off of this scenario, what they're presenting with, what would you think, high likelihood, what are some diagnoses that it could be? Heart failure is one of them, obviously, right? What else? Why neurogenic shock? But that usually you have to have, if it's neurocardiogenic shock, they're going to have falling off a ladder and hitting their head or doing something more severe than that one would be. What about coronary artery disease? He gets chest pain with exertion. It could be just coronary artery disease, atherosclerosis in the coronary vessels. We don't know, but some of those cardiomyopathies have a viral antecedent event. Pericarditis has a viral or illness preceding event. So by me telling you these things in that question, I'm telling you you don't have to worry about any type of infectious process for this case because I'm telling you there's no infection. So medical history, this patient has long-term hypertension, hyperlipidemia, type 2 diabetes, family history, and smoking history. So he's got a lot of risk factors for heart disease, right? Okay, let's keep doing this case. Vital signs, blood pressure, 140 over 85. Is that controlled, not controlled? Not well controlled. If he's got high blood pressure for 10 years, he should be on medication. That pressure should be lower than that. Heart rate, normal, and that part, regular. So we know there's no irregular heart rhythm, there's no atrial fibrillation. We don't have to worry about any of those things because their heart rate is normal. Do not, in a question, start getting in your head, oh, it's regular, but they could still have atrial fibrillation. No, just stop. I told you it's regular. Get all that out of your brain. Don't even go to atrial fibrillation because it's not going to be there. Okay? Respiration, 16. Is that okay?
Yeah.
And O2 stat. Good. So his breathing is okay. General appearance, well nourished, slightly overweight male, no acute distress. That's fine. Cardiovascular examination, no visible JVD. What can we start getting rid of now? Right-sided heart failure because there's no JVD. Any type of pericardial sac issue because there's no JVD. So now we can get rid of JVD, we can get rid of, we can get rid of pericarditis, we can get rid of right-sided heart failure because they don't have any JVD. PMI is displaced lateral. What would cause the PMI to be displaced lateral? Hypertrophy. So we know the heart is getting bigger because the PMI has gotten displaced. Presence of a systolic thrill, palpable right upper sternal border. Systolic thrill. When you are feeling for thrills, what are you doing? You're putting your hand over the valvular areas and you're feeling for what? Vibrations, thrills, they're little vibrations. What is that you're feeling for? Turbulent flow across the valve. And the more severe that valve damage is, the more likely you are to feel those thrills. S1 is normal, but S2 is single and soft. What are some reasons for a soft S2? S2 is what valve? S2, aortic. So a soft S2 is due to the stenosis. Remember, when you have a wide valve and it's fine, coming together is going to make a nice sound. But when you have them stenosed and it's quieter, because it's a smaller area to make a sound. That's why S2 is soft, because of aortic stenosis. Also, systolic thrill. So that tells you right there, this is a systolic murmur. There's only two systolic murmurs. What are they? And mitral regards. There are some others. You'll learn about them later with Dr. Ovey. But for this class, there's only two. Then, let's describe this murmur. 3 out of 6. Okay, now we're starting to creep up into those. Remember, 1 out of 6 is nothing. Crescendo, decrescendo, systolic murmur. Okay, that tells you right there. Aortic stenosis, right? The murmur decreases in intensity with Valsalva maneuver. What other condition are we trying to rule out when we do Valsalva maneuver? HOCM, hypertrophic obstructive cardiomyopathy. I have a description for this later on, so we'll stop here for now. Lung examination, clear to auscultation bilaterally. No adventitious breath sounds. Let me look. No ABS. So if you're in my advisee, just write that out for a lung exam and you're good to go. That's all you need to write. Abdomen, non-tender, non-distended. Okay, I will mention one thing to you guys about tenderness, and those of you who went through me for skills exams know what I'm talking about. Tenderness has to be elicited from who? The patient. I cannot do a magical exam on you, not ask you, did this hurt, and then report there was no tenderness. So you always have to remember to ask a patient, let me know if this hurts when I do this. Let me know if you feel any pain. And they say, ow, that hurts. And you say, tenderness elicited upon palpation of whatever you were doing. But you have to ask the patient that question. No hepatomegaly, so we know the liver is not engorged with blood. Again, right-sided heart failure can cause engorgement of the blood in the liver because it's got trapped and congested there. What's that reflex? Hepatojugular reflex. And what does that do?
You hold it down and then you see an increase in the J.
By pressing on the liver, in a normal heart, that blood should be accommodated by the heart and pumped out. But because we have right-sided heart failure, we have congestion on the right side. When you squeeze on that liver, all the blood's coming up the IVC, stays in the IVC, goes up the SVC, translates up to your jugulars, and as you press on the liver, you'll see the JVD rise with pressing down on the liver. That's the hepatojugular reflex. We don't have it here, so we know right-sided heart failure is out. Extremities also, no peripheral edema, and pulses are equal and normal bilaterally. That tells us a few things. One, no peripheral edema. There's no signs of heart failure. There's no signs of increased hydrostatic pressure in the legs, pushing out, causing the swelling to happen. Pulses are equal bilaterally. It means that you have good flow all the way down to your toes. So we know that the vascular system is still supplying blood to your extremities. Remember, one of the early signs of heart disease is that peripheral obstruction of the vessels. And it gives you a symptom. When you start walking, you get pain in your calves. What's that called? Intermittent claudication. It's an obstruction of the vessels that feed your legs. And we can assume if they have vessel damage in their legs, they have vessel damage in the coronaries as well. And that's why we look at that as an early sign of heart disease, because if you already got it in your legs, you probably got it elsewhere in the body. So here, pulses are equal, normal, and bilaterally. Vessels are okay. We don't have a vessel problem. We're still getting good flow. I can feel your pulses throughout the entire legs and the arms, so I know blood's getting to where it's got to go. Okay, electrocardiogram shows left ventricular hypertrophy. You'll know what that is when we get to EKG later on, but we can see the chamber sizes on EKG. So we're noticing that this EKG is showing signs of left ventricular hypertrophy and normal sinus rhythm. If I say something has normal sinus rhythm, where does every single beat originate from? The SA node. So we know if I say it's normal sinus rhythm, we know that the electrical activity of the heart is normal because the EKG is normal. So I can rule out any electrical problems for this person's heart issue because the heart is working the way it's supposed to work. Chest x-ray, cardiomegaly with a prominent left ventricular silhouette. So we know left ventricular is being hypertrophied. Now we've discovered many ways to prove LVH. PMI has been displaced, LVH. EKG shows LVH. Chest x-ray, LVH. And we'll see on the echo, also showing LVH. So the heart's been under stress for a long period of time. We've confirmed it on multiple diagnostics. Chest x-ray also shows some calcification in the aortic valve. Main cause for aortic stenosis is just age and calcification of that valve. Calcium is white on x-ray. And when you do chest x-ray, you may see some deposits of calcium around that ring in that area. Echocardiogram shows an aortic valve area of 0.8. What is a normal aortic valve area? It's like 4 to 5. Okay, this is really, really low. It's called severe stenosis. We also show a mean pressure gradient across the valve at 50. Why is there a pressure gradient across the aortic valve? This is the pressure that's generated from the left ventricle and the pressure that's in the aorta. Why is the ventricular pressure generated so much higher than the aortic pressure? It's due to the stenosis. We're trying to get the same volume of blood through a smaller hole. So the ventricle has to generate a lot more pressure to get across that fixed stenosis. But remember, our systolic blood pressure is determined by the arterioles in the body, the aorta, and so forth. Your systemic blood pressure is not really related to whatever the ventricles are generating. In this case, the ventricles have to generate a lot of pressure to overcome that fixed stenotic valve, but once it gets past the valve, the pressure is fine. So the heart generates like 220. In this case, what was the pressure here? 140 over 80. So this person's ventricle, if you put a catheter inside the ventricle and measure the pressure generated, the ventricle will probably be generating around 200 at this point. But the aortic and the blood pressure is only 140. That's that that pressure gradient across the valve. That's what that is referring to. Left ventricular ejection fraction, 55%. How's that? Good. And we have concentric LVH. What type of conditions cause a concentric hypertrophy of the left ventricle? Aortic stenosis. Aortic regurg causes what type of hypertrophy? Eccentric. So you see now how this echo report gives you everything you need to know. It tells you the ejection fraction, tells us the type of hypertrophy they're going to have. It also tells us gradients, aortic valve area, mitral valve areas, all that fun stuff you get all from that echo report. Okay? So, what are the two conditions that can present with a murmur of this type? Aortic stenosis and your HOCM. So which one did this patient have? They had stenosis. Why do you know they had stenosis? Okay, got softer with Valsalva. Aortic stenosis murmurs will get softer with Valsalva. This is important, you got to know this one. Why with aortic stenosis with Valsalva? Has to do with your preload. After this, we're done. I know it's 11:15, but we have a longer break. And you don't have 2:30 class. 2:30 ophthalmology is canceled, everyone know? So after this, you just got farm with Dr. Wood at 12:30, then you guys are done for the weekend. No class on Monday. If you want to come, have a blast. No one will be here. But no class on Monday. Tuesday, normal class. Wednesday is your ClinPath exam. Remember, for ClinPath and this semester, all exams this semester, you only get 1 hour, 60 minutes. So all the exams, 1 hour. Okay, so preload. When we Valsalva, we're increasing the intrathoracic pressure. When that happens, that pressure compresses the chambers of the heart. They can't fill as well because of the increased pressure from the lung, or the intrathoracic pressure. When you do the Valsalva, you decrease your preload. Less blood going through the heart. Remember, what are murmurs? Turbulent flow across a valve. If there's less blood moving across that valve, there's less sound because there's less blood. So when you do Valsalva and that crescendo, decrescendo murmur gets softer, it's aortic stenosis because of preload changes. With Valsalva, with that increased intrathoracic pressure, with the decrease in preload, that decreased preload makes that septum that's hypertrophied in those HOCM patients push into the left ventricle because there's no preload popping that ventricle open. It's weaker. So that pressure pushes in HOCM that septum to creep into the outflow tract. So let me just change this again. So here's our thickened septum. There is your aortic valve up there. Blood should go in that direction, right? Because up here is your mitral valve. So blood goes in that direction. When we have hokum, this septum pushes out and it bows out. And you reduce your outflow tract. Makes the murmur worse because the hokum, that septum, is invading that space. This is called subvalvular stenosis. So I mentioned before, watching those drug commercials. One of the popular ones are for like Xarelto, for people with AFib, so it helps prevent the clots from forming. It's the safer version of like Coumadin. If you listen to it, it says does not work for subvalvular stenosis, which is what this is referring to. So again, what is subvalvular stenosis? This is happening below the valve that's causing a stenosis. Hokum will do this. A thickened septum can cause an outflow tract obstruction, mimicking a stenosis, causing a murmur to happen. Everyone good now between hokum and AS? Because I know you'll get it in PD a lot. Okay, so I'll post this lecture. Let me know if you have any questions. I'll see you guys next week.